So good evening, each one of you have joined for the World Preeclampsia Day webinar series that lasts the whole week it started actually on May 22nd yesterday, and till May 28th, we are having a webinar on the different aspects of preeclampsia and fetal growth restriction, Samrakshan and preventive radiology. This is jointly organized by the IRIA Samrakshan Committee and IRIA Preventive Radiology Committee, along with the cooperation of several state chapters. 9 to 10 state chapters have joined us, and Kerala state chapter is taking the lead to host this webinar today. So once again, welcome each one of you. Before going into our academic session, I'm extremely happy and honored to have the privilege of the state presidents and secretaries from Punjab. The IRA Punjab is a very vibrant and dynamic state chapter, with the president, Dr. Mukesh Gupta ji, showing doing a lot of work, so in the social front as well as in the academic front. And the secretary, Dr. Amandeep Singh, who is a professor in the Amritsar Medical College, who is doing extremely good academic work. And also, he is the national coordinator for Ulsav Wing, which is a wing of IRIA that celebrates all festivals and bring in the concept of unity of our country, and enhance and gives the insights into the members of IRIA from different parts of the country on the different festivals being celebrated all over the country. So that the good team of, and along with them, I have the pleasure and to have the state president of Kerala IRIA, Dr. Gomadi Subramaniam, and she's the national coordinator for the social wing of IRIA. Another gem of a person who is doing a lot of social work as well as academic work for IRIA. So this is a very good panel of chief guests we have today here. So I've once again, thank you all for joining the chief guest. So let me introduce and welcome and invite the president of Punjab IRIA state chapter, Dr. Mukesh Gupta ji, to say a few words to us. Mukesh Gupta ji, sir.
I am thankful to Kerala IRIA to invite us as a chief guest. It is an honor to Punjab IRIA, and especially thankful to Dr. Gomati, President IRIA Kerala, Secretary Dr. Matthew, both of you are doing a great work in social as well as in academics. It is unparalleled. We have never seen such a work at national level for the last few years. And at the same time, I want to say a few words for the Samrakshan. Samrakshan word has been coined from Sanskrit and in Hindi, and in English it is protection. So we are protecting the mothers who are sufferers from preeclampsia, and we are celebrating preeclampsia week this time. And 8% of the population of India is suffering from preeclampsia, which proves to be later on perinatal mortality. And by making awareness, Punjab IRIA has going to initiate a program at district civil hospital where underprivileged mothers are coming, and we will offer our services of color Doppler in first and third trimester at very concessional rates to them to screen these mothers who are going to be the sufferer. And at the same time, we are going to organize awareness programs among the gynecologists, neonatologists, and paramedical staff at different levels in the society. Thank you very much once again, Kerala branch. And at the same time, I say good evening to Dr. Lalit, who is doing a lot of work in MP. I am very much impressed from his work in Samrakshan, and I'm going to talk to him. I want his advice to start my program at the same level in Punjab, but he is an example to all of us. And I am also saying good evening to our speaker, Dr. Gulab. We are going to have a good talk about the pathophysiology of preeclampsia. Thank you very much once again.
Thank you. That was Dr. Mukesh Gupta, the president of the Punjab state chapter of IRIA. So it is, we are thankful to you on behalf of Samrakshan Committee and Preventive Radiology Committee for have offered here to take the great lead in Punjab and to incorporate this particular program in district hospitals and to start the awareness campaigns with obstetricians and neonatologists. Thank you very much, sir. Now let me move on to another dynamic leader from Punjab, the Secretary of Punjab State Chapter, Professor Dr. Amandeep Singh, doing phenomenal work in the academics as well as on the social front of IRIA. Welcome, sir, and may I invite you to say a few words to this august audience.
Thank you so much, Dr. Riju, for such a generous introduction. Dr. Gomti ma'am, the president of the Kerala IRIA, Dr. Riju Matthew sir, secretary Kerala IRIA. Then we have Ramesh Shenoy sir with us, a dynamic personality entirely handling the digital wing of IRIA. To anything digital we require, we just go to Ramesh Shenoy sir. Dr. Lalit Sharma sir, and I feel privileged to be here with you. Dr. Gulab, Dr. Soumya, Dr. Mukesh Gupta, our president. Now, about Dr. Riju sir, Samrakshan, the brainchild of Riju sir. I tell you, when this Samrakshan was launched, we were always like, what is this program going to be? How is it going to be helpful? How is it going to? And now we have a big publication on this Samrakshan, how this is affecting the perinatal mortality, the mothers. Now, every time the major focus was mainly on detecting these congenital abnormalities. And we never focused on this preeclampsia screening. Whereas what we find is this preeclampsia, this is causing more complications as compared to the congenital abnormalities. So program started on the national level by Dr. I really congratulate him, hats off to him, the way he has handled it, now celebrating this World Preeclampsia Week. It is really, actually, this is the basic part in any preventive program is at first counseling, at first education. And first educating ourselves. And then we are going to transmit this knowledge to our patients, to the mothers who require at least early detection of this preeclampsia. Now, I give you an example, like celebrating this preeclampsia week. Just now in the morning, I got a call from a very senior radiologist. He said, I want to join this Samrakshan. I said, we have these groups in Punjab, in various states, what we have formed, and you can join this group, and we'll be very happy to have you. So this is all what is awareness we are spreading. And I tell you, Dr. Riju, hats off to you. You are not only doing a preventive program, but you are saving many lives, not only mothers, the children that are going to be born. And really, I big applause for you. And especially for Kerala IRA, Dr. Gomti ma'am, Dr. Riju, you are just the trendsetters. We all are just follow you. The Kerala is doing this, doing that. I tell you, doing brilliant work. Any support from Punjab IRA and anything will always be there. You'll be the guiding light for all of us. Thank you. I won't be taking much time, and we'll be starting all the NET program as scheduled. Thank you, Dr. Riju.
Thank you, Professor Dr. Amandeep Singh, the Secretary of IRIA Punjab.
One thing I would like to mention here also, as Samrakshan has started, now what we are doing in a medical college, we are giving a thesis topic related to this Doppler to every candidate here almost. For the last 2-3 years, I'm giving the topic related to the uterine artery Doppler during first semester, during NT scan. So in this way, when a candidate does a thesis study, he or she is more interested in the patients, right? Yes, and then also we have a good follow-up for that patients. So this we are incorporating and helping Samrakshan in this way.
Yeah.
So thank you. Samrakshan is in safe hands in Punjab, and with so many ideas, so many good new initiatives have already been announced by the President and Secretary of Punjab IRIA, and I'm extremely happy that this will take shape in Punjab in a big way. And thank you, Dr. Mukesh Gupta ji and Professor Dr. Amandeep Singh. Let me now invite the President of IRIA Kerala to address us and say a few words about Samrakshan and the World Preeclampsia.
Yeah, thank you. Very, very, very good evening to all of you. I'm seeing eminent faculties in front of me. I'm so happy that the lead of IRA, that is the Punjab team, is with us today. And I'm so happy to see them because they are doing splendid work, which is very inspirational to all of us. And many are seeing them and doing many, many works everywhere. So I'm happy to see you today and to be here with us celebrating the pre-eclampsia week. I just wanted to tell that, as Dr. Amandeep said, this Samrakshan and preventive radiology goes together. That is, we are giving protection for the mother and we are saving the child. So by this, we are reducing the perinatal mortality and perinatal child death also. So this is very, very important. And as you said, I am just giving as a teaching program to the residents. And you said we have already given research works to the residents. They're doing on first trimester, second trimester, and third trimester. And as you said, we are following up, and we have put a protocol in our that is antenatal room for doing USG, the protocol for doing the first trimester, second trimester, and third trimester. This rule should be followed by everybody in each district, in all hospitals and throughout India. That's what we want to do, so that will be a very good a learning lesson for all of us, so that we not miss anything by doing the ultrasound scan systematically. This is what we want. So we want to do this and conduct sessions and how to do this program in our state. We thought we'll be doing it in every district. We'll tell the city chapters to conduct the preeclampsia program by telling them how to prevent the reduce the mortality rates in the pregnant women. So this is what we are going to do in our Kerala, and I think we should follow this all the states, so that it will be very helpful to all. So I'm very thankful to be here today, and we'll go on with the talk. Thank you so much. Unmute, Rijo.
So thank you, Dr. Gaumadi Subramaniam ma'am, the president of IRIA Kerala, who gave us an inspirational message and a commitment that movement in some direction will be taken forward in Kerala in a great way. Thank you, ma'am. Now we will move on to our academic session. Actually, Dr. Lilish Sharma sir has a technical problem. The first talk, I think I have given introduction on some direction. Let me share my screen. Is my screen visible?
Yes, doctor.
Okay. So I don't take much time, because so much has been said about Samrakshan, what Samrakshan is, but still there will be members of IRIA and those who have joined new and want to know what exactly this Samrakshan is. I'll just give a why Samrakshan was introduced and what is Samrakshan and how Samrakshan worked all these 3 years and what were the results Samrakshan had. This is a very brief presentation I will go through. And Samrakshan is a national program of Indian Radiological and Imaging Association to reduce avoidable deaths of mothers and babies during pregnancy and childbirth in India, led by a dedicated team of fetal radiologists in India. Why we have started Samrakshan is, if you look at this statistics, out of the total 128 million live births, the total live births in India, 27 million are in India. If you look at the stillbirth rate, perinatal mortality rate, neonatal mortality rate, infant mortality rate, child under 5 mortality rate, whichever indices you look at it, 25% of it to the world data is being contributed from India. Every year. So if you look at low birth weight babies, out of the 20 million low birth weight babies, nearly 8 million are in India. Out of the 2.6 million stillbirth babies, nearly 6 lakhs are in India. Perinatal mortality, out of the 28 lakhs, 7.2 lakhs are from India. So this is a huge problem that India has, but has been made, governments and non-government agencies has been trying their level best to improve the primary interventions by having better socioeconomic status, improving nutrition, etc. But it has made some progress, but it has not made the accelerated progress that we require to reduce it to the levels of a developed nation, or reduce it to even to the level of the levels of sustainable development goals to the 2030. That levels, if we want to achieve, it is still a long way to go. So if you look at the neonatal mortality in India, these states, Rajasthan, Uttar Pradesh, Madhya Pradesh, Chhattisgarh, Odisha, they contribute to 50 to 55% of perinatal and neonatal mortality in India. So we need to work focused on the areas where these indices are high, where maternal deaths are more, where the perinatal deaths are more. So, and there is a very interesting study in 2016 that came, what are the causes of perinatal deaths in India? If you look at it, preterm births and complications were 43.7% and intrapartum or birth-related complications were 19.2%. That is 71% basically related to prematurity and birth-related complications. Only 8.1% deaths in the perinatal and neonatal mortality was due to congenital anomalies. But what were we as radiologists doing? We were looking for structural anomalies. Of course, that is important, but we have ignored two components which could have been easily diagnosed and prognosticated with the help of our imaging technologies. Those are the two areas, that is fetal growth and the assessment of feto-maternal environment. So our pregnancy scans as essentially got three components. The one is a structural integrity of the fetus, structural. And the other two components of pregnancy scans was on for fetal growth and another one was on the feto-maternal environment. So all these years, we have not given the sufficient attention that it deserves. But in a country like India, where we are practicing, we have realized abnormalities of the fetal growth and abnormalities of the feto-maternal environment are the major contributors to maternal deaths and perinatal deaths in our country. And it is time for us to focus on, and that is why the core two major determinants of perinatal mortality in India are preeclampsia and fetal growth restriction. So the goal of this program was to supplement and complement existing efforts to address perinatal mortality in India through a synergistic and holistic approach that includes all stakeholders in fetal care. So if you look at all the stakeholders in fetal care, who are the major stakeholders? Of course, the patient and their family, that's a major stakeholder. Apart from that, the obstetrician is a major stakeholder. Neonatologist who takes care of the baby is a major stakeholder. But there is an invisible stakeholder who has been there for last 30 years and can play a significant role. That is a radiologist who can assess for the structural abnormalities of the fetus and also can prognosticate and assess about the fetal growth and the feto-maternal environment. So connecting the thought process of all these major stakeholders is very important. And then a obstetrician is more worried about preeclampsia, maternal diseases complicating pregnancy, preterm births, stillbirths, intrapartum complications, about the timing and mode of delivery. Whereas a neonatologist is more worried about the prematurity and complication, whether it's a low birth weight, perinatal asphyxia, about poor neurodevelopmental outcomes, respiratory distress, infections, NICU management, etc. So radiologists were initially, even now, concentrating more on the congenital anomalies with more focus and much more larger focus on aneuploidy and genetic markers, but a component that can be added into our services or can be added into pregnancy scans is a screening for fetal growth and the feto-maternal environment, assessment of fetal growth and feto-maternal environment, and screening for preeclampsia and fetal growth restriction is an integral part as in our scans. It has to be. And the other major stakeholder in this thing from the society side is the government. But the governments, if you look at their efforts, they will be always focusing on the primary interventions like improving the socioeconomic status and improving nutrition, etc. But what we are trying to say through Samrakshan is by a targeted approach leveraging the technologies, imaging technologies, we can stratify those mothers and babies who are at risk for developing preeclampsia and fetal growth restriction. And if we can modify their risk, we can bring out better results and can reduce significantly the problem of maternal mortality, the problem of perinatal deaths in India in a significant way in a relatively shorter span. Rather than all these 75 years after independence, we have been putting so much of money, so much of effort to reduce these indices but the progress that it can be really accelerated if we approach the Samrakshan protocols by stratifying the high risk groups and applying the targeted approach towards the modification of the disease process. So we had the Samrakshan 7-star program, which had multiple dimensions, which was a promotional campaign, then a technical package that skill enhancement for radiologists. We got 20,000 radiologists in this country, and organized CMEs, hands-on live demos and workshops on the Samrakshan courses. And there was a synergy programs with the obstetricians and neonatologists, and also to promote the Reksha and the PCPNDT training programs. And also there was a research, evaluation, and audit component, because we wanted to apply some of the models that are available like for screening, and to put them in practice in the Indian scenario, and to see that whether these are working. And we did that. And finally, one of the aims of the 7-star program was to submit a national policy document to the health ministries of the governments for this particular strategy that we want to highlight. So the structure of the team was there's national coordinator for Samrakshan IRA 2022 this year is Dr. Shilpa Satarkar. Joint coordinator is Dr. Lalit Sharma. There were several subcommittees, the academic committee, Dr. Bavaharan, Dr. Isha Rajput, Dr. Mridula Bapat, so many people others. The state CME and training program, Dr. Sandhya Dhankar, in the evaluation committees, Dr. Gulab Chaja, Dr. Anjali Gupta, Dr. Praveen Nirmalan, awareness committees and social media, Samrakshan has been, different aspects of Samrakshan has been highlighted in the social media, and thanks to Dr. Ramesh Shena and his attempts, Dr. Lalit Sharma, Dr. Divya Pandey, Policy and Guidelines Committee, Dr. Devarajan, Dr. Srinivas Shenda, Synergy and Reach Out programs with obstetricians and neonatologists, Dr. Agancha Bagel, Dr. Neelam Jain, and there are so many other people whom I have not mentioned here, but they have played significant. This is a committee for this year, but from 2019 onwards, this program for IRIA is actively performing. So I'm not going into the details. Again, these are the multidimensional Samrakshan action plan. I'm not going into the details of the program, because this whole week we will be having several sessions on the stepwise management and the skill enhancement program. What we wanted to highlight was there is a systematic evaluation of a mother with a maternal history, and after that we have to take a mean arterial pressure that taking blood pressure from both the arms and twice, and that will give the mean arterial pressure. And after that, the uterine artery Dopplers also has to be done. So these three parameters, when we put it in the online calculator, it will give us the risk. What is the percent risk? And the cutoff that we took for India was 1 in 150. And those mothers who are at risk of more than 1 in 150, we advise them for low-dose aspirin. And low-dose aspirin from the ASPRI trial, as well as from the several studies that were done, even our own series that we did for the last 2 years, have shown that it can be reduced to 80% preeclampsia. The chance of developing a preterm preeclampsia can be significantly reduced. So we have got in India, we have got nearly 8 to 10% of gestational hypertension, the chances of preeclampsia. So out of the 3 crore pregnancies in India, nearly 30 lakh mothers can get hypertensive disorders in pregnancy. And they are the candidates who are likely to go for preeclampsia and eclampsia. And those babies are those who are very likely to go for fetal growth restriction. So if we can reduce the 80 to 80% of them, it can be reduced, means we are making a significant impact on the 20 lakh population, or 20 to 24 lakh population, and that can significantly reduce the perinatal mortality rate and even the maternal mortality rate in India. So as part of this program, we conducted several CMEs. This program was announced at Chandigarh National Conference of IRIA during the presidential tenure of Dr. Hemant Patel, and it was launched at Sono Summit, Chennai, and the first CME was conducted in Indore 2019. After that, several CMEs were conducted in Agra, Trichy, Tirupur, Kerala, Bhubaneswar, Jabalpur, Ahmedabad, Maharashtra, Chandigarh, Chhattisgarh, And there were during the COVID, we had several online webinars with a large attendance of 700 to 900 participants in each webinar. And there were several reach out programs in smaller places in India, because we believed that 70 to 80% of perinatal deaths or maternal deaths are happening in places below the tier 2 cities in India. So we wanted to concentrate on those cities, reach out to the obstetricians and neonatologists there. And Dr. Lelit Sharma conducted reach out programs in Guna and Sagar, Guna, and Dr. Agansha Baghel conducted it in Harda, and in Dr. Suresh Sabu sir conducted it in Jalna. And there were several reach out programs that in Gwalior also recently a reach out program was conducted by Dr. Lelit Sharma sir. So several programs happened. And we also concentrated on the community involvement of this part, because this was not just an academic conference, holding a conference and saying a few leaders coming there, giving expert talks and then motivating you to do it, but most of them won't do it. But we just wanted these leaders to come out with talk in the patient's language. So there were several health education articles written, video messages, and there were arts and poem series, and there were original articles from the Samrakshan database, videos on 11 for the training and skill enhancement program, several interviews. All these things are available on the IRIA website, iria.org.in. In the social media, the presence of Samrakshan was very vibrant and dynamic, and in the Telegram as well as in the YouTube and the WhatsApp groups of Samrakshan were formed, and several communications on the academic programs and the skill enhancement programs were shared. And in the WhatsApp groups, a lot of discussions used to happen, and still it is happening. The end of 2 years, we published several papers, and one of the paper that has been published recently in April is Reducing Perinatal Mortality in India and the 2-year results of IRIA Fetal Radiology Samrakshan program. This has been published in the Indian Journal of Radiology and Imaging in this issue, April. And the aim of the study is to determine improvements in perinatal mortality at the end of first 2 years from the initiation of the Samrakshan program of the Indian Radiological and Imaging Association. So methods, Samrakshan is a screening program, basically a trimester-specific risk assessment protocols, including the maternal demographics, mean arterial pressure, and fetal Doppler studies to classify women as high risk or low risk for preterm preeclampsia and fetal growth restriction. Low-dose aspirin 150 milligram daily once at bedtime was started for pregnant women identified as high risk in the 11 to 13 week screening. The third trimester screening focused on the staging of FGR and protocol-based management for childbirth and risk assessment for PE. Outcomes of childbirth, including gestational age at delivery, and the perinatal mortality outcomes, and the development of preeclampsia and the perinatal mortality outcomes were collected. So the radiologists from 38 districts of 16 states of India participated in the Samrakshan program that screened 2,816 first trimester, 3,267 second trimester, and 3,272 third trimester pregnant women respectively. At 2 years, the preterm preeclampsia was identified in 2.76%, preterm births in 19.28%, abnormal Doppler study in 25%, and the neonatal mortality rate was reduced to 9.86%. The perinatal mortality rate in our series was 18.97 per 1,000 childbirths, and maternal mortality was 58 per 1 lakh live births, compared with 29.5, 36, and 113 respectively. That's a national average in 2016. So the conclusion of this study was very, very encouraging. Fetal Doppler integrated antenatal ultrasound studies in using Samrakshan protocol can lead to a significant reduction in preterm preeclampsia rates. Preterm birth rates. There is almost preterm birth rates were halved. Preterm preeclampsia rates were came to 1/3, and a significant improvement in the mean birth weights also. The perinatal, neonatal, and maternal mortality rates are significantly better than the targets for 2030 set by the Sustainable Development Goals 3. So this is what Samrakshan wants to tell everyone, including the governments. So having said that, having proved with the study, with the teamwork, with the kind of infrastructure that we have created, with the kind of systems that we have created, we have motivated a large number of radiologists all over the country to apply Samrakshan into their practice. But government still may have queries on how on the health economic analysis. But if you honestly look at it, the cost of having a preeclampsia treatment and the loss of mother and babies, if a low dose aspirin which costs 1 rupee per day, with a very minimal cost for screening, with the screening using Dopplers, the cost effectiveness or the cost benefit analysis, if you look at for the whole nation, this program can make a lot of difference. What we need to all the administrators, health administrators also has to consider the problem of the low birth weight babies and fetal growth restricted babies of developing adult cardiovascular disease, metabolic syndromes, and diabetes, obesity, etc., and the future generation with a lot of disease burden that can be avoided at this point of time if using it in this window of opportunity. So this also has to be accounted into. And all the challenges we have is the consensus has to come between all the stakeholders, obstetrician, neonatologists, and the radiologists on applying this screening protocol. And amongst the radiologists itself, the priority has to be given in the 11 to 14 week scan. Honestly, ask yourself, I've spent so much time on NT, NB, and structural anomalies, but did I do the preeclampsia and FGS screening? Because the number of babies that you can save, number of mothers you can save are 10 times that compared to what you could save with screening for congenital anomalies or chromosomal anomaly screening. And can Samrakshan be applied to all levels of healthcare in India? It is possible to do it even at the taluka levels in India, secondary and tertiary care levels of healthcare. So the Samrakshan offers a lot of possibilities here. And I've just given a brief description of Samrakshan, but it's a lot of effort that has gone behind Samrakshan. A lot of people have taken painstakingly work for it. A lot of people have contributed to the form submission. A lot of people have given the talks and volunteered to give several lectures, skill enhancement programs, even peer-to-peer learning programs of Samrakshan is still happening. Dr. Anjali Gupta, Dr. Shilpa Satarkar, Dr. Neelam Jain, Dr. Baba Heran, a lot of people who are Dr. Lalit Sharma, Dr. Aganksha Bagel, a lot of the Samrakshan committee members, Dr. Kavita Aneja, Dr. Sandhya Dankar. I have to thank a lot of people who are taking a lot of efforts. But in the beginning of Samrakshan, when this idea was mooted, two people who have been instrumental in supporting me in shaping up it with the technical portals and all, that was Dr. Ramesh Shanai and Dr. Praveen Nirmal. After that, for the academic session, National Academic Lead, Dr. Bavaharan, Dr. Devarajan, and course directors, Dr. Neelam Jain, Dr. Sanich. There were a lot of people involved in that phase. After that, it has really taken off in a big way. But for a country like India, we need to have more and more people involved in this program. So even though your heart desires or the mind designs, we need more and more skilled hands to execute this project. So once again, I appeal each one of you to join this Samrakshan program and make it and reduce the perinatal mortality in India, reduce the maternal mortality in India. Thank you very much.
Dr. Rijo, you have a question.
Yeah, madam.
That is it possible to skip BP measurement while screening for preeclampsia?
No, that will significantly, if you do only the maternal risk assessment, only 40% will be picked up. If you do only MAP, again, the incidence, the pickup rate for this preeclampsia and this thing will be considerably less. That is why the combined screening methodology using maternal demographics, mean arterial pressure, and the uterine artery Dopplers are advocated. And those patients who can afford and those who can have access towards the lab where we can add the biochemical parameters of PAPP and PLGF, placental growth factor, that again can improve the detection rates to 90%. Whereas with with these three parameters, the maternal demographics, mean arterial pressure, and uterine artery Doppler PA, we can nearly pick up 80% of mothers who are likely to develop preeclampsia. So because lab accessibility and affordability is not there for cities below the tier 2 cities below in India. So Samrakshan in the initial phase has not recommended the biochemical parameters. But if you go only by maternal demographics, which nice guidelines and all went for it, their screening protocols didn't work well. Many mothers were missed and there was no significant improvement in the perinatal outcome or the maternal mortality. So that is why the combined screening protocol is very, very important. Thank you, ma'am.
Yeah,
So,
then one of the host is not host. Somebody has asked that I tried to register many times on Samrakshan, but could not appear because of malfunction. I couldn't understand that question.
Samrakshan resources, Samrakshan form submission, online form submission. If you want to submit forms, if you want to understand the Samrakshan process, all these resources are available in www.iria.org.in. Go to the programs and Samrakshan and click. Everything is available free of cost. You can access right from the beginning of whatever the initial document that I presented to the IRIA national office on what Samrakshan is and how do we plan to take it. Right from those documents, everything is available. There are a lot of videos, a lot of publications, a lot of journal articles, a lot of things accessible there.
He says app appears to be malfunctioning. That's why I couldn't follow. It is functioning for us, but he's saying it's not. I don't know. Okay.
Yeah, we will check it. We'll check it.
Thank you, Dr. Rijo, for such a beautiful talk. It was very informative. Those who are listening is really, really informative. Thank you so much for giving such a wonderful talk.
Thank you, ma'am. So let us move on to the next talk. Actually, Dr. Lalit Sharma sir had a technical problem, so he couldn't join. So we will move on to the next talk, that is pathophysiology of preeclampsia. Let me invite the young radiologist who is a Samrakshan warrior, who is a young of the Yuva Brigade of Samrakshan, Dr. Gulab Chajar from Pali, Sumerpur, Rajasthan. And he did his post-graduation radiology from Madras Medical College, having a very good practice in Pali, Sumerpur, Rajasthan, and has contributed significantly for Samrakshan. With that introduction, may I welcome Dr. Gulab Chajar to give the pathophysiology of preeclampsia.
Good evening, everyone. Thank you, Rijo sir, and thank you, Gomti ma'am, and our office bearers from IRIA Punjab, Dr. Amandeep sir and Dr. Mukesh sir. So we'll be kickstarting the academic sessions on this preeclampsia week. So the first talk will be on the pathophysiology of preeclampsia and how does it affect the fetus and the mother. So I'll start my screen. Is my screen okay?
Yes.
Okay.
Yes.
Okay.
Gulab. Yes. Gulab.
Yeah. Okay. So in the next 20 minutes or so, we'll be looking at on the pathophysiology of this very important determinant of maternal and perinatal mortality. So I have been practicing at Sumerpur in Rajasthan for the past 5 years, and my education was completely in Tamil Nadu at Chennai and Coimbatore. So preeclampsia is a pregnancy-specific disorder characterized by the new onset of hypertension after 20th gestational week and is accompanied by one or more of the following conditions such as proteinuria, thrombocytopenia, renal insufficiency, impaired liver functions, pulmonary edema, and cerebral or visual symptoms. And as the days progress, the definitions and the criteria for diagnosing preeclampsia is slowly getting changed, that even without proteinuria also there is a possibility that you can diagnose preeclampsia. So that is still on the research stage which is going on. So important to understand that this is a very drastic disorder which results in a significant maternal and perinatal mortality. So it affects 3 to 8% of the pregnancy worldwide, and various pathological mechanisms are involved in this process, ranging from placental ischemia to hypoxia, and at the molecular level there is imbalance between the angiogenic and the anti-angiogenic factors, lots of inflammation and production of antibodies. So it is that is a vicious cycle, and it is linked with prematurity, intrauterine or the fetal growth restrictions, and small for gestational age fetuses. So first we're looking at the anatomy pertaining to uteroplacental unit. So the uterine artery, which we evaluate regularly on our NT scans and the anomaly scans and the third trimesters. So uterine artery is a branch of the internal iliac. So it reaches close to the uterus, and then it gives rise to the branches called as the arcuate arteries. So these arcuate arteries will run parallel to the surface of the myometrium, and this will give rise to radial branches across the myometrium. So these are called the radial arteries, and then these give rise to the basal arteries, and basal arteries in turn and give rise to the spiral arteries. So the spiral arteries are the ones which are reaching close to the innermost surface of the endometrium, where the placentation is going to happen. So this is the crucial zone where all the gas exchange and all the placentation takes place. So now look at this image. So this is the fetus, this is the umbilical cord, this is the fetal end of the umbilical cord, this is the maternal end of the umbilical cord. So this is the placenta, and this is the fetoplacental unit. So now we'll be looking at this part in zoomed image. So this is the umbilical cord, which is coming from the fetus, and this is the maternal myometrium. So this entire unit is the maternal and the fetoplacental unit. So in fetal life, what you are seeing that there are two umbilical arteries which are marked in blue, because they are arteries, but they carry deoxygenated blood. And what is marked in red is the umbilical vein. So despite being a vein, it carries the oxygenated blood. So reverse of what happens in adult life. So these branch into their respective branches, such as fetal venules and fetal arterioles, and from the maternal sides you have maternal arterioles and the maternal venules. So this process, this place where all this meet, this is within the intervillous space, and where the gas exchange takes place between the mother and the fetus. So the mother has to deliver the oxygen to the fetus, so that will give all the nourishment to the fetal unit. So now time of placentation is important. Implantation happens at 6 to 12 days. Initiation of the trophoblast invasion happens at 6 to 8 weeks, the time when we do our early pregnancy scan. The establishment of the uteroplacental perfusion happens at 11 to 14 weeks when we do our NT scans, and there is conclusion of the trophoblast invasion that happens at when we usually do around the anomaly scans. And there is conclusion of the circumferential placental growth, and there is end of new vessel recruitment by around 28 weeks. So any error during this process, especially during 6 weeks to 20 weeks period, when there is inadequate vascular remodeling or inadequate trophoblast invasion. So this will complicate and result in reduced perfusion, and that will result in clinical manifestation of impaired placental perfusion, usually diagnosed after 20 weeks. So how does placental remodeling takes place? So why is that initially the placenta is an high resistance unit, and as the pregnancy progresses, the placenta becomes an low resistance unit. So as the pregnancy advances, the endovascular trophoblast cells invade the maternal blood vessels at the terminal portion of the arteriole. So this is the fetal side, and this is the maternal side. So from the fetal side, you have the fetal blood vessels, and which are arranged in this pattern, and there are cytotrophoblast and the syncytotrophoblast, which are arranged around the fetal blood vessels, and they start invading the maternal blood vessels. So the migration of the trophoblast cells then occurs along the inner walls of the arterioles in sheets pattern, with the deposition of the fibrinoid material on the luminal surface. So once these trophoblasts reach the spiral arteries, there is an accumulation of cells almost leading to the point that it forms a spiral arterial plug. So initial during the first 10 weeks of gestation, there is lots of migration and there is lots of invasion of the spiral arteries happening. So this spiral arteries takes times to remodel. So during that period, before the 10-week period, this results almost to the point of occlusion. So in this period, if you measure the uterine artery resistance, it will be the highest at any point of time in the pregnancy. So at this point of time, the maternal blood flow is severely reduced, and support for the embryo is largely dependent on the uterine glands for the first 10 weeks of gestation. So now whenever there is an inadequacy, that acts as a stimulation for the next process to happen. So minimal blood flow early in pregnancy and the resulting hypoxic environment will help direct the trophoblast proliferation and differentiation, and alters the endovascular smooth muscle cells response to this external stimuli. So this is important for trophoblast mediated vascular remodeling. So at around 12 weeks, what happens, that is integrity of the trophoblast plug diminishes, and the vessel caliber enlarge, the plug loosens, and there is sufficient blood flow is allowed into the intervillous space. So then the trophoblast migration continues, and it continues beyond the spiral plugs into the deeper myometrial segment of the arteries, that is a terminal portion of the radial artery. So this is where the entire remodeling takes place from the level of the spiral arteries, and it reaches up to the level of the radial arteries. So that is where the tight fetoplacental unit forms. So any error in this period will result in processes like preeclampsia. So now what happens at the cross-sectional level? So trophoblast invasion will result in disorganization and removal of the tunica media. So this is the cross-section of the vessel. This is the tunica intima. This is the tunica media. This is the tunica adventitia. So this is what happens in non-pregnant state. This is how it looks. During the pregnant state, what happens is this tunica media, that is a muscle layer, is actually replaced by lots of trophoblast cells and the remnants of fibroblasts and fibrinoid deposits. So what happens is, as there is loss of smooth muscle and the elastica from the spiral arteries, this converts this entire high resistance system into an low resistance system. So now the spiral arteries will lack the ability to constrict in any significant manner, and they will allow more blood flow to the fetus. So now that is how the uterine artery PI continuously drops in pregnancy. So when we see during the NT scan period, and when we see during the third trimester. So during pregnancy, the spiral arteries are continuously invaded by trophoblastic cells. There is dilatation of the spiral arteries. This creates a low resistance, and this decrease in the PI index. So now the RI is obsolete. So PI is pulsatility index. There is continuous falls in the pulsatility index or the resistance pattern. Now, the main pathological feature of this early onset preeclampsia is incomplete transformation of the spiral arteries, resulting in hypoperfusion of the placenta and reduced nutrient supply to the fetus. So this is the crux of the talk, that the main underlying pathomechanism that we understand is that the spiral arteries which are to be transformed or which are to be remodeled doesn't get remodeled, and there is hypoperfusion to the placenta. So this will result in sequence of cascade of events like hypoxic injury and oxidative stress. So this again is the same. So we are just repeating this this process so that the pathophysiology gets implanted into our brains. So this is the non-pregnant state. This is how the arteries look like. Normal pregnancies, the arteries dilate and the trophoblasts are migrated along the walls. In preeclampsia, the vessels don't dilate so much, and they lie somewhere between the non-pregnant and the normal pregnancy state. So again, the same thing depicted in this image. So this is preeclampsia is a process where the remodeling happens somewhere between a non-pregnant state and a normal pregnant state. So what happens at the molecular level? So there is an imbalance of pro and anti-inflammatory markers. So we have two important markers, that are this thromboxane A2 and the prostacyclin, that is a PGI2. So now both these are produced through the arachidonic acid pathway. So COX-1 and the COX-2 respectively acts on arachidonic acid to produce prostaglandin H2. which in turn leads to formation of prostacyclin and the thromboxanes. Now this prostacyclins, which is produced from the endothelial cells, is an effective vasodilator and has an anti-inflammatory properties, whereas thromboxane promotes platelet aggregation and is an important vasoconstrictor. So any imbalance between these two will result and will have a potential impact on the vessel wall. So now what happens in preeclampsia is there is upregulation of the thromboxane. So it promotes more platelet aggregation and it promotes more vasoconstriction. So there is suboptimal trophoblastic invasion. This leads to again imbalance of the angiogenic and the anti-angiogenic proteins. So now that will result in widespread inflammation and endothelial damage, again increased platelet aggregation and thrombotic events with placental impact. So these are all happening at the micro level. So imagine this placenta, so much a big unit, and there are a lot of events happening at the molecular level all over the placenta. So if more than 30% of the placenta gets affected, then you start manifesting signs of preeclampsia, fetal growth restriction, and so on. So normal pregnancy, the diameter of the vessels is usually 500 microns, whereas in preeclampsia, this diameter reaches up to 200 microns. So now we have two types of preeclampsia: the early onset and the late onset. So what is more important in quantity is this late onset, that characterizes at about 80% of the cases. But in early onset type, the clinical signs appear before 34 weeks, and in the late onset they appear after 34 weeks. But the early onset is a type that is responsible for most of the high maternal and fetal mortality morbidity rates. So that is why Samrakshan comes into play, that we have to diagnose these early onset types starting from the anti-scan period, so that these don't land up into prematurity and fetal growth restrictions later on. So difference between early and the late onset. So early onset is less common, manifested before 34 weeks, and they have abnormal uteroplacental Doppler waveforms associated with fetal growth restriction, severe maternal and neonatal outcomes associated with extensive placental lesions. Whereas the late onset are all they are the majority of cases, they manifest after 34 weeks. They're milder forms of the disease, and there is less fetal involvement, and maternal and fetal factors proposed to have more of an influence, less associated with placental lesions. Now, the important to understand is that even though early onset preeclampsia is less common, but given an Indian population of 150 crores and pregnancies happening in India to the tunes of crores, so this is a very big number considering our nation. So what are the risk factors? Now, most important risk factors are the maternal antiphospholipid antibody syndrome, that is the APLA. This has a 9-fold increased risk. That is why it is included in the screening protocol. There is a column for the history. Then, if there is history of preeclampsia in a prior pregnancy, so that increases the risk to 7-fold. Then diabetes, hypertension, that is hypertension before the pregnancy starts. Multiple gestations, African American background, accessory reproductive techniques like IVFs, and obesity will all act as risk factors for preeclampsia. So now, what happens at the micro levels in the placenta? So these all is what you will find in the histopathology reports of preeclamptic placentas when delivered and subjected to microscopic examinations. So ultimately, what is the final point? So whatever is the cause, ranging from fetal genetics to maternal genetics to inflammatory causes like diabetes, obesity, hypertension, dyslipidemias, SLEs, APLAs. So all this will result in widespread inflammation, and there is oxidative stress happening at multiple levels. There is extensive decidual inflammation, and ultimately this will result in acute atherosclerosis, or the vessels or the small vessels at the spiral arteries, and these vessels are getting blocked at the spiral arterial levels. So this will result in hypoperfusion. So now, role of biomarkers. This is slowly gaining pace. Recent studies indicate that poor placentation is associated with imbalance of the circulating vasoactive, and in turn leads to maternal vascular maladaptation with associated systemic endothelial dysfunction. Now, when this happens, when there is poor placentation, lots of placental products are released into the bloodstream, and we can actually measure these products into the from the bloodstream and get an assessment of how much of the defective placentation is happening at the maternal level. So now these markers include PAPA, placental growth factor, soluble FMs like tyrosine kinase 1, soluble endoglins, activin A, and inhibins A. So now what are the maternal outcomes with preeclampsia? So if it is a preeclampsia, it means it is pre. So it will lead on to eclampsia. So that results in 2 to 3% of the women diagnosed with preeclampsia with severe features who are not receiving anti-seizure prophylaxis, and up to 0.6% of the women diagnosed with preeclampsia without severe features. And maternal sequelae can include intracerebral hemorrhages, transient blindness, and cardiorespiratory arrest. And what we are more concerned about mother is the permanent neurological sequelae from brain ischemia or hemorrhage due to preeclampsia and ultimately resulting in maternal death. So what are the fetal outcomes in preeclampsia? Most important are the fetal growth restriction and oligohydramnios. Parental death is usually due to premature delivery, placental abruption, and intrauterine asphyxia. Fetal outcomes are largely complicated by the gestational age of delivery. So that is where we can play a role. We can guide the obstetricians that when to deliver and by what method to deliver, how long we can wait, how long not to wait. And neonatal complications such as necrotizing enterocolitis, respiratory distress, ARDS, and intraventricular hemorrhage, and all those of prematurity will result due to this drastic disorder. Final slide on one word on aspirin, that this is the game changer and very cost effective. And the aspirin, this results in inhibition of inflammation and platelet aggregation, could be useful to prevent and treat preeclampsia. Most important is that we have to start it as early as possible. So once you start screening the mothers at 11 to 14 week period, and if the risk for the preeclampsia or the fetal growth restriction high, you start the patients on 150 milligrams of aspirin, so that you will get sufficient time for the mother that the placentation happens quite well. So thank you everyone for the patient listening, and we'll be having a series of talks this week. I thank Team Samrakshan, the IRIA and ICRI office bearers, and all those who have joined today for this talk. Thank you one and all.
Thank you, Dr. Gulab Charger, for nicely explaining the pathophysiology of preeclampsia. So, Gulab, can you explain from your practice, what are the screening protocols that you follow for preeclampsia, and how are the outcomes in Pali, and how Samrakshan has improved your practice in Pali?
Yes. So, shall I stop sharing my screen?
Yeah, you can.
Yeah, stop sharing. Yeah. So this is one. This is the part of the Western Rajasthan, and it is very quite. I stay in a tier, even in a smaller place than tier 2, maybe between tier 2 and tier 3. So when I came here, and there were a lot of this deaths happening at the late third trimesters with unknown reasoning. So once I joined this project and started implementing the protocols, we have seen a tremendous drop, or we can say that we have seen a good pickup of cases where you have diagnosed early, we have delivered either on time and not prolonged too much, or we have delivered on time and saved a lot of babies. So this somewhere impacts your practice so that people start believing that you are a person that you can rely on, that how to means when to deliver, means can I prolong this pregnancy for 2 weeks more or 1 week more, or can I stop till lung maturity, or have to deliver today. So that has this project and implementation of this protocols has certainly resulted in improvement in the neonatal and the maternal outcomes. So here we are adding and we are counseling more and more people. We are creating more and more awareness regarding this project, and on how we can deliver the outcomes. So this is what we are just replicating of what is happening at Kerala.
Yeah, there are actually we missed Dr. Lalit Sharma. Actually, we have missed out today on the experiences that would have been shared by Dr. Lalit Sharma sir, because there's a Guna model that is a fantastic model that has been worked out. And for the last 3 years with Samrakshan protocols, he could significantly reduce the maternal deaths and perinatal deaths in Guna. And that is why the district administration and the district collector there, Mr. Frank Nobel, has taken the lead of making a wider implementation of this project with 38 Anganwadis. And now the project itself, they've renamed it, called as IRIA, this Barosa, that's a faith. That program is doing very well, and that has been presented to the Niti Aayog and the health ministries, and that they have seriously taken up that project. And similarly in Harda, Aganksha Bagel is doing a wonderful project called Samrakshan Integrated Clinics. So these are the kind of models that are developing, evolving, and those leaders of Samrakshan at different places of the country, they are innovating and applying it. And that is what the whole charm of Samrakshan is. We just started the project, but now it has moved on to different parts of the country. People have taken ownership for it and they're leading it. And Gulab Charger in Rajasthan is doing a phenomenal work there. Gulab, looking, Gamadi ma'am, do you have any doubts or any such, questions to be asked?
Yeah, questions is there. When do we get the biomarkers done for preeclampsia? Gulab, Dr. Gulab?
Yes,
when do we get the biomarkers done for preeclampsia?
Biomarkers are done as early as possible, especially during the anti-scan period.
Yeah.
See, let us understand this in this way. Bioimaging, we are having the imaging biomarkers, and uterine artery Doppler is an imaging biomarker. And a biochemical marker, if you look at it, they are the PA, PPA, and the placental growth factor. But placental growth factor, many labs, if you consider it's a pan-India perspective, below tier 2 cities may not be available. But essentially, we have to ask for the maternal demographic, maternal history of the parameters that Gulab had already shown about the hypertension before that, the previous pregnancy, whether it is obesity, and all those parameters has to be asked. Then the mean arterial pressure. This is very, very crucial. We cannot avoid it. Just after all, many people will say that taking blood pressure is not our work. This is what we faced when the initial phases of Samrakshan. Many people said we don't. I said I am also not doing it. But I have trained my staff to do that. When what we need is 2 electronic automatic sphygmomanometers that you can purchase from Amazon. It costs only $1,500. So 2 sets of it, and train your staff to take this twice and give it in there are Samrakshan forms are there that you can download from the IRIA website. Take a printout of that, ask your staff to take the maternal history, and one of your smart nurses or the typist, they can take all these parameters when the patient is waiting, and the BP also can be measured. And by the time the patient reaches, you can have the initial part of it, look at it, and you only are taking the uterine artery Dopplers. You take the, you know how to learn, you should to skill enhance yourself to take uterine artery Dopplers at 11 to 14 weeks. Take the mean PI. And then even the online calculators that are freely available from the FMF Foundation as well as from the Barcelona Fetal Medicine Foundation. So those calculators, in my centers, my typists know how to do it. I am not doing the online calculation by myself. They know it, and the finally risk can be. They will be giving you the risk that comes automatically there. But now we are trying to integrate with the help of a software, the whole these processes. With the Samrakshan we are going to automate it with the help of a reporting software, so that only thing again you have to do is taking the uterine artery Dopplers and all the biometry as well as the Doppler parameters will be directly through a DICOM mode. It will be directly taken over by the software. Online calculators also it will do. It will give you the risk and that will be shown in the report. And the recommendations, if it is a screen positive, also will be coming in the report. So we are currently automated the process, and it will be soon. The training process will start on that.
Akanksha Baghel has given a number. She said anybody finding difficulty in filling the form can contact her. She has given a number 887-845-6875. So all of you can note if they are finding in difficulty, try to contact her.
Yeah. So the major challenges radiologists will have at institutional level practice, and they say that we don't have a system to take blood pressure. So that they were asking for shortcuts, that can we take the BP that is measured by the gynecologist in the OPD and all this. But this is not the way. We have to measure it in a proper way. The patient, both the foot has to touch the ground, and patient in a sitting position. That's an ideal protocol that has to be followed. So these are the learning techniques. These are the skill enhancement programs that are part of Samrakshan. And once it is, you learn yourself and teach it to your paraclinical staff, it becomes very easy. And but screening will definitely improve. There is a question that everyone used to ask: if aspirin is so effective, why can't we give low-dose aspirin to all the mothers? But we have to remember that we have got nearly 3 crore pregnancies in India, and 10% of it, that is 30 lakh mothers, are those mothers who are likely to go for preeclampsia. And we have to screen that with the help of this combined screening methodology. We have to give aspirin only for these 30 lakh mothers. We don't have to give aspirin for the rest of the 2.7 crore mothers, which is not going to make any good this thing for them. So that is where the screening comes in. And again, a few questions related to questions that come up during when you start implementing the screening protocols is whether this aspirin, whether it is 150 milligram or 75 milligram or 81 milligram, because the gynecologist has got different guidelines. They follow the American college, which is still not accepting the 150 milligram. Why they are not accepting? Because for their Caucasian population, 75 milligram is okay. 75 to 81 milligram is okay. The whole calculation, whole thing about preeclampsia and FGR is what we need to understand is all the data or the consensus statement, everything that has come from the West, their incidence of preeclampsia is only 2 to 3%. Their incidence of fetal growth restriction is only 2 to 3%. Whereas India has got 8 to 10% incidence of preeclampsia and a 25 to 30% of fetal growth restriction. So our cutoffs will be different. We have to apply it for our population. That is what the Samrakshan research also has proved us. So 150 milligram is required because Indians are more resistant to the effects of aspirin. So we need 150 milligram at bedtime. At bedtime is preferred for more compliance. Well, these are the areas that we will have to reach out to the obstetricians and have a dialogue with them, convince them, and put these things into practice. Because even if you're screened and we say that it is screen positive, but if the patient has not been advised low dose aspirin, there is no point in doing the screening. So there is a lot of synergy. Reach out programs has to be done with obstetricians too, to make them aware of the screening protocols, make them aware of the importance of giving low dose aspirin, so that there can be a significant reduction in maternal mortality, significant reduction in perinatal deaths in a very short period. That is what we are again using a technology. We are going to accelerate the reduction of perinatal mortality in India, and that is possible if all the stakeholders, major stakeholders, the professional stakeholders, the radiologists, the neonatologists, the obstetricians come together and act together. It is possible. That is what Samrakshan wants to tell you.